Good afternoon, everyone. Thank you all for being here with us today. This Tuesday, September 2nd, 2025, here at the Dr. Ricardo Chapa Boardroom Administration Building. At this meeting, there may be discussion by the board on the items and subjects listed as follow. Item number 1, call the meeting to order. I've done so at 5:30 p.m. Item 2, public comments. We have no public comments today. Item number 3, discussion and possible action on approval of self-funded medical plan rates and benefits for 2025-26. Dr. Gutierrez.
Yes, Mr. President and the Board of Trustees, the district sponsors a self-funded medical and pharmacy plan. For its employees, the district works with a benefits consultant to develop and implement a strategic plan with funding and cost control strategies. Mr. Andy Silva, our Director for Employee Benefits and Safety Risk Management, will present a report, and at the end of the presentation, the administration is requesting approval on this item. So I'm going to go ahead and turn it over to Mr. Silva to go over the PowerPoint. Mr. Silva.
Good evening, Board President excuse me, Rivera, trustees, Superintendent Dr. Gutierrez. So yes, this evening we're going to be sharing some of the potential strategies that we've talked about in prior meetings and asking you to consider approving some of the recommendations that we've discussed. So if I could direct your attention to that first slide there. There's 7 strategies that we've talked about before, and so I'll go over them briefly, and then I'll summarize them in a slide there later on. So the first strategy there was for the district to budget an additional amount into the health plan fund. So it was to increase the employer contribution by $55 per employee per month. That actually has already happened. So for tonight, we're not asking for any action on that item. That's actually was part of the budget development process. So that one's in place. We expect that to generate about $2 million in additional revenue. And as you'll see later in one of the slides, that is still not sufficient to bring us into the black. So that's why some of these other recommendations are necessary. Strategy number 2 is to increase the employee premiums. This is a strategy that we do model almost every year just to do our due diligence. It's a strategy we're not recommending tonight. A decision was made early on that despite us having it as a potential strategy, that we were not going to make that recommendation. We were going to look to see if we can find savings elsewhere to make up any potential revenue that we could have made by increasing employee premiums. So strategy number 2 is not one we're recommending here tonight. Strategy number 3 is a standalone discontinuation of one of our 3 major medical plans. So we have 3 plans, what we call the basic plan, the high plan, and the state plan. And so we were moving towards a single plan model. So on a standalone basis, one strategy would be to slowly work our way to that point by discontinuing the state plan, which is our richest plan. However, it also has the highest loss ratios. So it was one we were considering discontinuing on a standalone basis. We're not recommending that as a strategy. The reason for that is because we're actually recommending strategy number 4. Strategy number 4 is to discontinue not only the state plan, but also the high plan and move to a single plan model. Single plan being our basic plan. And I'll show you what our current basic plan looks like here in a future slide, and then what the potential changes to that plan would be. In terms of dollars, that one change potentially could be a $3.5 million impact, so very significant to go to one plan. Strategy number 5 is related to number 4. So in addition to going to one single plan, we're recommending making some adjustments to that one single plan, the basic plan. Adjustments would be a deductible change, an adjustment to a specialty copay, introduction of an inpatient hospital copay, and again, I'll show you what those look like here in a bit. There was actually 4 options we had looked at here. We're proposing the more conservative one. Potentially it could save $230,000, but we did model all the way up to a $2,000 deductible, so that would be doubling it from the current $1,000, and a savings of just shy of $1 million. Again, that's not something we're recommending here tonight. we're recommending the increase by $250 to $1,250, which potentially has a savings of $230,000. And again, I'll show you what that looks like here in a future slide. Number 6 is also something we're recommending. It's a strategy to create a 4th pharmacy plan tier. So currently we have 3 tiers. Each tier copay is $750, $25, or $45. So all drugs fall into one of those 3 categories. But we do have a lot of medications that are considerably higher than $45, up to $1,000 or even more. And so one strategy would be to develop a specialty plan tier specifically for those drugs. And so that's what we're presenting here. Not only is it very specific, it's very specific to GLP-1 medications. So not all specialty drugs, which they could be a lot of them, just specifically to GLP-1 medications. So that narrows the scope, lowers the impact to the members, reduces the number of medications that are potentially fit in that category. That change potentially could save us at a 20% coinsurance, $185,000. At a 30% coinsurance, $278,000. So that's something I failed to mention. This tier would not be based on a standard flat copay. It'd be based on a coinsurance. And our recommendation is for it to be based on 30% coinsurance, which is consistent with our medical plan. So our medical plan, basic plan, has a 70-30 coinsurance. So 70% is paid by the plan, 30% is paid by the members. This would be consistent with that. This particular tier, 70% would be paid by the plan, 30% would be paid by the member. So that's another one of the recommendations. Number 7 here is to implement a 340B RX mail program. This is what we talked about also. It's taking advantage of a federal program to purchase drugs at a substantial lower cost. This one actually rolled out effective yesterday. So we've already implemented this, so we'll be moving into this program as our employees respond to the communications and get enrolled, and we should be able to get some savings there. So the next slide kind of summarizes these recommendations, and it shows dollar-wise why it's necessary. So to give you some idea, this fiscal year that just ended, our fund is going to be in a deficit of about $850,000, and that is with the influx of funds that were deposited into the fund of $3 million. So if we were to do nothing for this fiscal year, this plan year, we're looking at potentially a $4.8 million deficit. So we need to make some kind of changes. The first change that was made is going to have a $2 million impact. So that's increasing the employer budgeted contribution. But we still have some deficit to make up. So collectively, with these plan changes, potentially we'd be in the black at a $1.3 million. So it is something we need to do. The district can't be in a position to fund from fund balance, every year, certainly not to these levels. So it is something that we need to consider. Okay, if we can go to the next slide, please. So this is for reference. These are the 3 plans that exist currently. So basic, high, and state from left to right. Shows the current deductibles for both individual and family, current out-of-pocket for individual and family, some of the office visit copays, and the pharmacy drug copays. As you can see, they're all consistent across the board, regardless of the plan. It's $750, $25, and $45, and there you have the costs. Again, this is for reference as we go into the next slide. So this summarizes the recommendations. So that middle column there, current, that's the basic plan as it exists currently. What we're proposing is to move to one plan, that being the basic plan, with the additional revisions noted in yellow. So under the proposed column, you'll see that the in-network deductible would go to $1,250 from $1,000. That's for individual. The family deductible would go from $3,000 to $3,750. There's some comparable, consistent out-of-network changes that would occur also. And then in the out-of-pocket area, the individual would go from $5,000 to $5,500. The family would go from $14,700 to 15,000. There'd be a specialist copay adjustment of from 30 to 40, so $10. There'll be a new inpatient hospital copay of $300, and then the addition of a fourth pharmacy copay tier, as I mentioned earlier, specialty, specifically for GLP-1 drugs, and that would be 30% of the cost in coinsurance. So that summarizes the changes. There's a couple of reference documents in the following slides that you might want to look at as we discuss this, but that concludes my presentation, and we are looking for the board to take action on these recommendations.
Okay.
Andy, you mind if I ask a question? I want to ask a question on
Yes, sir.
the fourth tier for prescription drugs. How many of our, how many of our employees are on GLP-1s, or what percentage of our?
So when we first looked at it, and I have it noted there was about 142 on the drug that we were focusing on. That was Mounjaro. That was the drug that we were seeing the most new utilizers. It's a very expensive drug. We could not source it at a lower cost than we were getting domestically, internationally. Wasn't more advantageous, and that was 102, I believe, at the time. Let me reference that.
Okay, so I'm just going to do just very simple math. The cost savings of $278,000 divided by 102, that would potentially impose a $2,700 cost on each of these employees that they would have to pay out of pocket.
So I guess, and I haven't done the math
I mean,
like that.
obviously, that's just very simple math to first with each.
So you're correct that for every prescription, now they'd be looking at up to $300 per prescription. Now, what I will say is that
Oh, it's only, there's a max on per prescription?
it's a coinsurance. So if the drug's about $1,000, the coinsurance would be about $300 and some odd dollars. So that would be their portion.
Right, okay.
So per prescription. But not all employees would have to pay that amount. And I say that because there's programs out there to reduce that cost, manufacturer programs. And we, working with our administrator for our pharmacy plan, would try and leverage those to make sure that those employees have access to those. Classic example, this past weekend, somebody sent me a message that they had a coupon at the pharmacy they'd never seen before. It was for a GLP-1 medication. They didn't have to ask for it. Pharmacy automatically applied it. So there's programs out there so that the cost will be reduced from what the medical plan benefit is. So while there might be several hundred employees enrolled in these, taking these prescriptions, they may not all have to pay a coinsurance amount. The other thing to consider is that what we're doing here is developing a tier, a separate tier. In theory, it's a buy-up tier. There's drugs that are much lower costs for the same indications that the standard copays would apply. So that would be working with your physician to see if one of the others is more appropriate. If it is, they have options to potentially pay zero, because some of those drugs have programs where they don't have to pay a thing because we're directing them to very specialized sources, whether it be international, domestic specialty pharmacies where we found the cost to be lower. When we identify those sources, we put in programs where to switch, to get them to switch, there is no cost. So I say that, I guess, to try and explain that not everybody potentially would be subject to those coinsurances. Can I tell you that nobody will? That I can't say, because potentially some will.
And I guess I have the same question with the inpatient hospital stay. A 30% coinsurance, that can be a massive financial burden on our employees. How much is that specific supposed to
if I could, by your question, there's probably some confusion on how it's written. However, you're on the right track. So it's an inpatient copay, then services are at 30%. That exists right now. You're in the hospital, you have a coinsurance of 30%. That's existing currently. What we're doing is adding an inpatient copay. So right now, one doesn't exist. So you go to the ER, there's a $200 copay. If you're admitted, it was waived. So if you're admitted, you don't have to pay that $200 copay. If you exit the emergency room because it was something that didn't require inpatient stay, you're subject to $200. This adds $300 instead of the $200 if you're admitted. So $200, it'll be waived technically, but you're subject to $100 more because you were admitted, so $300. The coinsurance that you see on that note, that exists already. That's not new. It's only that $300.
That would deter someone from going if they needed to go. I'm sorry. That would be a deterrent to somebody going to the hospital if they needed to go.
So again, that exists currently. So it's changing it by $100 in essence.
So you're saying we're essentially, because I mean, there's very few direct admits to a hospital. They mostly come to the ER. So you're saying for the most patients that get admitted to the hospital, it's just an additional $100 charge.
From current, yes.
But to Trustee Sophia's point, I mean, is that penalizing patients who actually had an emergency?
My read is that no, it's not, because the emergency room admittance fee is essentially the same
But it's $100 more.
if you're admitted to inpatient.
Right. So I'm saying, like, if you go to the ER and you don't have an emergency situation, it's an outpatient, you'll be discharged. But if you do have an emergency situation and they need to admit you, we're gonna tack on $100 to your bill.
And it's an emergency situation. So is that person supposed to up and leave and say, like, well, I don't have an extra $100 this month and
Yeah.
I'm just gonna go home?
Good point.
Like, it's kind of not fair.
How much savings is that? No, it's just the $300.
Yeah, so that's on the schedule. Collectively with those three changes, the inpatient, the deductible change, and
Everything
the specialist adjustment, that is an estimated savings of $230,000.
Just the inpatient portion.
Collectively. We
collectively.
didn't model them separately. So those three changes collectively.
Like initially you were talking about, I think it was family deductibles. One went up from $1,200 to $1,250. One went up from $3,000 to $3,750. For a family, it was like 15. Let's see. I mean,
Yeah.
every single item almost went up here. Copay went up $10. Everything on this plan went up.
No, just those few items. There's a lot more benefits that are not listed here. These are typically what you put in a summary. X-rays, labs, there's, chiropractic care, all those kinds of things, a bunch of other summaries. These are like the most frequently listed on plan summaries.
Can I ask, I guess the vendor that we chose and voted on for our insurance, how many years prior have they held this contract?
I'm sorry, I don't understand the question.
Whoever it is that we chose for our insurance.
Uh-huh.
So they have,
The new group
it's,
that we just
this
voted on?
is completely new?
Yes.
No, I think
It
she's
has not been
asking
finalized.
Blue Cross, is that, they're the plan administrator. They're
So
not
I guess
the-
I'm talking Roger Garza.
Oh, that's a consultant.
How long has he been with?
Probably
I mean, that's what my
6 to
my
8 years.
concern is, like, starting from slide one, like, we're in the hole, and yet again, we're using the same consultant. And now, because we continue to go this route, our employees are basically footing the bill. So, I know I've made those comments before about this. I had concerns early on, and this board decided to continue, so I just don't see what incentives we have for our consultant to find a plan that works for specifically our demographic. But
And
Here we are.
when was the last time that the plans, how long have these plans been in place, the current plans? How many years? Has it been years?
Yes. In terms of rates, the last rate change was 1/1/23. Prior to that,
In 2023?
2023, effective 1/1/23, there was one change. Prior to that, and that was I didn't present it this time, but that was a slide I had previously, showing the board, show the history.
But the 2023 had one change to the plan?
It didn't have any changes to the benefits. It only changed the rates, We went back and looked, probably at least through 2006, we can't find that we did benefit plan changes. The benefits have been consistent. The changes we had made were either to employer contributions and at least on 3 occasions in the last 15 years, employee rate adjustments. But in terms of employee and benefit plan design changes, there hasn't been many. And that's typically because, as you can see here, some of the impacts, there's some dollar savings, but they're not all that significant. So decisions were made that, okay, well, we'll see what happens next year, and we'll see what happens next year, we'll see that kind of approach. And so we wouldn't make benefit plan decisions very often. We hadn't made them in several years.
Yeah, 1/1/23, that's basically before 95% of this board was here. So, I don't know. I just don't know what the solution is.
Well, I think, one thing we're not looking at here is whether it's negotiations with, and that's why, we picked United Healthcare. I think we're going from Blue Cross Blue Shield potentially to United, is what negotiation power do they have with all the providers? Because this is where all our money's going. And Andy, you and I have talked about this, whether it's direct contracting, preferred provider, a tiered plan where, if one provider, high quality, provides us better rates, we, steer our employees that way, so it's a lower cost to the plan, and whatever that might be. But I think, Andy needs to have those conversations with our plans to say, y'all need to start helping us control these costs, not just administer. Use your negotiating rates here in the community and get that done.
Yeah.
Because that's why we have shortfalls.
So-
And what we're having to look at is how to impose the cost on our employees, unfortunately.
So 2 comments on that. So as far as United Healthcare, this recommendation, this modeling was done under the assumption of Blue Cross Blue Shield. We don't have any data yet we can turn to and say, oh yeah, United Healthcare is going to help us this much so that we can adjust accordingly. That'll come in the next year. So come this time next year, when I have to present to you any changes, I'll have that information to say, oh, United Healthcare, with United Healthcare, the claim costs drop this much. We don't have to fund as much. So that will be built into the next evaluation. Similarly, in terms of having discussions with United Healthcare, this going to one model puts us in a position to have potentially a new plan, such as you just described, once we get in with United Healthcare and have them work with us, develop a plan that has more advantageous discounts at a particular hospital or hospital systems, and we can develop a tier network, a certain plan that's more advantageous to us and to our employees, and we'd move into a 2-plan tier, from a 1-plan 1 year to a 2-plan the following year. The reason that's not here now is because we didn't have an opportunity to have those discussions with the new group. We're just now getting started with them. That doesn't happen until January 1st, and this plan year, it starts January 1st.
So for almost the whole year, our employees will have to pay more out of pocket.
Based on these, potentially pay more out of pocket. Because these are recommendations that potentially there'll be greater out-of-pocket costs if you're utilizing the plan. If you're one of those employees that has routine office visits primarily, you're not on a GLP-1 medication, you won't see much of an impact. If, on the other hand, you have hospitalizations often or an emergency hospitalization, yes, you'll see additional out-of-pocket expense compared to what they see now.
But this is not, is this an issue that, you know, we're voicing some concerns here that's unique to our district, or is it this like what I'm hearing, deductibles are going up everywhere?
It's
And-
definitely not unique to our district.
Like how reflective, I mean, I'm not trying to, I'm just wondering how much is just our economy that we're in and what we're seeing.
So, and Ms. Garcia's coming to that shows you comparatively how we are current to other school districts. We're not all aligned, not all deductibles are the same, not all the pockets, but we all struggle with the same things. And the levers we can pull are benefit design changes, they are increasing rates, increasing employer contributions, all those kinds of things all at once or separately. But all these school districts, I can assure you, struggle with these same kinds of things every year. They just handle them individually, you know, however their administration and their board feels comfortable.
So what, I'm sorry, Lucy.
No, I'm done.
What would happen if we don't approve this today?
So
What's the
if-
alternative?
Sure. So if we don't approve them and the direction is we make no changes, potentially be in a pretty significant deficit at the end of this fiscal year based on the projections. If United helps us in terms of lower claim costs, well, that deficit might be considerably reduced. That, at this point, I couldn't tell you. If the direction is to come with something different, we can. I just need some direction on what kinds of things you would consider.
There are some things that we can't control. I'd like for Andy to give you all an update on our high-cost claimants, because we recently got hit with quite a few, an unusual amount in this month.
So in a span of 2 days, I typically get notifications currently from Blue Cross of what's considered a high-cost claimant. That's a claim that has hit a hospital typically exceeding $80,000. I usually see, you know, 1 or 2 or 3 a month. And they could range, you know, 100,000 here, 200,000 there. In a span of 1 weekend, Friday and Monday, got 5 notices that collectively was $3.5 million on 5 claims. So that contributes to where we're at now. Whether that be different with United Healthcare, I couldn't say. Potentially, it depends on what hospital system, depends on what the situation was. All of those are variables.
I'm trying to wrap my head around all of this. This is very new for me, so please forgive me if I'm
Not at all.
asking some basic questions. For historical perspective, if our projection for 25-26 is a $4.8 million in the red, how does that compare to, let's say, the past 3 years?
So this past year, we had anticipated $800,000 in the deficit, and that's where we landed.
Yeah.
Prior to that, we actually had a positive fund balance of about $69,000. In both of those years, there was additional funds that had to be transferred in. So while we managed to manage reasonably well, it wasn't without help. Had it not been for those additional funds, they would be in the deficit as well. And again, that's a function of a process every year. How much money is available for raises, for health plan adjustments, and decisions have to be made.
Yep.
So a decision could be made to leave the health fund budget alone. Potentially, we're going to need some help during the year at the end of the year. And so it's been some very tough last couple of years.
Yeah.
Yes.
But it seems to me, with that said, that the 25-26 projection is an outlier above and beyond what the past 2 priors have been.
It is, I would say yes, and an outlier, but it's based on overall trend going back several years.
Yeah.
So, yeah.
But
Compounded.
we did infuse $3 million this past year,
Yes.
in addition to the $850,000 deficit that
Yeah.
we're gonna land.
Uh-huh.
So it's really 3.8.
That's helpful. Yep. And that's 3 million above the $55 increase per employee per month,
Yeah, so-
employer contribution.
It was prior to us making the
Yes.
$55 increase change, it was
Yep.
prior to that.
Okay,
But-
that's
but-
very helpful.
Yes, but a little, I guess, background for those of you that weren't here. That was a decision that was made before the last budget cycle that
Yep.
we're going to hold the employer contributions, we're going to hold the employee rates, with the understanding we're probably going to need some additional money this last, and that's how it worked out. It was projected, there was going to be a deficit, and it turned out to be a deficit.
Yep.
Even with the additional funding that was put in.
Yeah, thank you. And thank you, Dr. Canales and Mr. Silva, for the conversation earlier. I'll just share here where my concern currently lies, and it's a combination of what's in Attachment C and Attachment D. And I actually think the information that's shown on Attachment D is obviously an increase in some pretty significant areas, but it's only currently showing the side-by-side for somebody that's on the basic plan today and would be on the basic plan on 1/1/26. My concern is the roughly 600 or so employees and families that are on the high plan today or the state plan today, which is 1 out of every 6 of our employees who would be seeing a pretty significantly different change in their benefits and coverages, and most specifically in the out-of-pocket maximums, right? So let's say an individual is currently on the high plan. We'll just throw the basic out, or the state plan out for now, because it's a relatively small number of folks. The difference in the out-of-pocket maximum, accounting for the savings that they might have on a monthly basis, is $2,300 at the individual level. And the savings at the family level of out-of-pocket, or excuse me, $1,000. And a family that's on the high plan currently, an employee with their family, out-of-pocket maximum is going to increase by over $2,200. And my mind goes to the families that have chronic illnesses or that on an annual basis are definitely going to hit their out-of-pocket maximum. That $2,200 feels like a lot. And I recognize we've got to figure out a way to make this whole. But when I go back to the balance sheet on Attachment B, it's hard for me to feel like this suite of proposals is the right step when we actually end up $1.3 million in the black. Now, I understand that on an annual basis things change and we don't want to cut it too close to even, in recognition that on a given weekend we might get hit with 5 high-cost claims like you just described. But to me, that feels a little bit high, given the amounts that we've heard in terms of where we've been over the course of the past couple of years.
I'll just make one comment to that. Unlike what the business office has to deal with on a recommended or required fund balance, we do not have one for this specific fund.
Yeah.
But we've developed a strategy, and it does change. It's a percent of our liability, a percent of our claims over a 3-month period, pharmacy and medical. The number of an ideal fund balance for a fund like ours, the last figure I have is about $6 million. That's where we should be on a regular basis. So 1.2, 1.3, while it might be a lot looking at it here,
Yeah.
it's still considerably lower than really where we should be. And the reason it needs to be higher is for those shock
Yep.
claims, those things that happen unexpected, beyond our control, we need to be able to fund for.
Yeah. So a follow-up on that. Is it fair to assume that right now the fund balance in the insurance fund is 0 if we're running in the red?
It's in the red,
$800,000.
$848,000.
Yeah. Okay. Thank you for that additional information.
Andy, sorry. go ahead.
No, go ahead.
2 questions. One, I guess to put in perspective, because we're talking about the deficits, but what is the planned spend in 25, 26? Well, I guess we don't have that yet. But in 24, 25, And in the past 3 years, what did the plan pay out? Has it gone increasingly higher, or did we just eat up any positive balance we had?
You mean the total expenses? From that standpoint, I have
Correct.
that number. We landed at 28 million,
At 28 million?
28. We're projecting 30 million for next year, a
Okay.
$2 million increase.
And then on to Trustee Carrion's point, is it legally allowed, can we keep the state plan and freeze enrollment at whoever's in it now? And then, just let it, because I assume that most of the families in there are in there for a reason, that they have high medical costs, or there's a reason they're on the state plan.
I'm gonna defer that one, kind of put legal on the spot. I think we can close enrollment. It'd be like a plan that's sunsetting. That's something I can look into. I don't have an answer for you right now, because that's not something we consider that are researched.
Is that, on option 3, attachment A,
Self-funded.
discontinued state plan, that saves us $500,000. So
we can, 'cause we're
presumably
self-funded.
that would add $500,000.
We own the plan. We own the plan,
We own the plan.
I'm assuming we could,
because we own it.
but I'm gonna defer to Andy. I'm just kidding. You're gonna need to give me 2-3 days to do some homework on that to make sure. I'm confident we can, because it is our plan.
Yeah.
I wanna make sure I don't give you all bad advice and you
Yep.
take
We
action on
own-
it without letting me do some homework.
Yeah, we own the plan, and so I think it's doable, but you can check on that. But it's something that, these plans are our own plans, they're self-funded. All our funds is because of employee contributions to the plans, and that's how we are able to have our self-insured program. I know it's not an easy decision, but if we don't make changes, then we will continue to bring budget amendments to take money from fund balance to cover the medical cost. And that's what we've been doing for the last year to now. We want to see how we can, right now, it looks like for every dollar that we put in as employees, 3 are going out. And that's what the problem is. We need to put it where $5 going to the plan, but $3 go out, so that we can sustain a fund balance and maintain the cost where we're not in the red. And so at some point, we have to make some adjustments to the plan. Unless we want to continue dipping into fund balance and bring you budget amendments, we can do that and leave the plans alone. But if you look at our plans in comparison to the state plans, Andy, you're more familiar with the smaller districts have the state plan with TRS Active Care. You ought to see their rates. They're through the roof.
70%, I think.
But because we're self-funded, we have a very good plan. And even these changes are it still puts us in a very good plan. It doesn't put us in a very expensive plan. It puts us in a very good plan to sustain it, because we are the ones that own the plan. We are the ones that finance the plan. And so if our employees cannot sustain it, then we have to get it out of fund balance.
So can
That's where we are.
May I interrupt, Mr. Silva? So you're using the GLP-1s as one of the more expensive options or reasons why the plan is so expensive, right? I don't know how many people we have on GLP-1s, but I'm going to use myself as an example. I have lupus and an array of secondary conditions. Just today, I was at the doctor and I had 4 of my meds changed. And the cost is going to be crazy, because at least 3 of them are really expensive, and even with my copay and everything. How does this impact someone like me? Because we're just concentrating on, you had a weekend with 5 high claims and you have the GLP-1s. What about someone with me that has a chronic condition that, you all see the Band-Aids every week and they rotate fingers. But how does that impact someone like me out of pocket?
So I guess generally speaking, in terms of the medications, if in your list of medications is not a GLP-1, that part wouldn't impact you at all, because this is specifically to GLP-1s. So unless you get prescribed a GLP-1, you wouldn't be subject to this particular change. As far as other visits, if it's a specialist, you'd go from a $30 copay to a $40 copay every time you go see a specialist. So that's a $10 change for each one of those visits. Similarly, if using the example of going into the hospital, so if it was an emergency and you were not admitted, well then that additional $100 doesn't apply. If you're admitted, then it's a $300.
How
So-
fair is that? Because I think that we have more employees that have issues like mine than we do the GLP ones. It's not
And-
fair.
And I'm going to say this without trying to be insensitive. The majority of the utilization is a small percent. So it's being funded by a majority of those that aren't having the expenses. So how fair is that?
It's not fair all the way around.
That's why I wanted to have it just focus on this item, because it is critical what we have. What I'm reading from the board is maybe we're not ready to make a decision. Let us go back and see at other possibilities. If you want us to look at some other hard numbers and look at other maybe ways that we can bring it back. But at some point, we gotta do some changes to some items. But maybe we can go back and look at it with our consultant and review some more numbers where it's not as impactful to the employees as we're talking about, but that there might be some changes.
I can't wrap my head around someone who has a chronic condition, more likely than not will end up in a hospital having to pay more, $100 more, $100 more every time, you know. I can't see, I shouldn't say punishing, but tacking that on to people who, my condition is for life. My condition has periods where it's dormant, but when it's active, and it's active right now, I'm at the doctor every week. I could or could not end up in the hospital today or Friday or next week, and I'm gonna have to pay $100 more. That's kind of not fair. That's why I feel like this, sticking to one plan and not having options for people who have more serious things. Because I know that if you have a doctor that you can talk into giving you a GLP-1 to lose weight, you're going to get a GLP-1.
That was my question.
And that's not hard to do.
So we have controls for that. There's at least four things that have to be met. One, it's the A1C number. There's a standard. You have to have that. Obviously, a diabetic diagnosis. And there's a couple others that I can't recite off the top of my head. But if there isn't those four things, then it's not approved. It gets denied.
So then we don't cover, is that bound, because that's the.
Is that strictly for weight loss?
That's the Manjaro for weight loss.
Then we do not. We do not cover weight loss medications. Our plan does not currently.
And I have to say,
They're made by the same
my
company.
apologies to any doctor out there that's listening. I'm not saying doctors are easily persuaded, but there is a doctor or two out there. I know somebody who's pre-diabetic on a GLP-1. I mean, you know, I feel like, how many, do you know, you said it's like 200 and some people that are doing the GLP-1?
It was 102 when we did this
Yeah.
analysis the last time, that were not on the full GLP-1s, that were on the Mounjaro that we were targeting.
So 102 people, but people like me are gonna get something tacked on because
112, I'm sorry.
112 people on GLP-1s, and this is why we're talking about this today. And again, I'm not talking about people who have diabetes. I have a brother that's got diabetes, and he goes through an array of stuff too. But for people who have the long-term chronic conditions that more than likely will end up in a hospital, they're the ones that get that extra charge. So I'm not ready to make a decision.
On that, if I may, on the GLP-1, may I, sir?
Please.
On the GLP-1, the other thing that a plan like this would do for us, in some form, future-proofs our plan, because for those of you that have tracked or are familiar, Mounjaro is like the latest and greatest, but there was some that preceded it. So as new drugs are coming on the market, they're more and more expensive. We had a huge increase in cost when Trulicity came. We didn't have any controls. It was subject to the same $25 or $45 copay. Then that faded away when Ozempic came. And that faded away when Mounjaro came. So there's going to be another drug after that and another drug after that, and they're going to be more and more expensive. So
How does it foolproof our future plans?
it puts us in a position, if we set it up as I described, GLP-1s that we don't know about today will be subject to this coinsurance 6 months from now, a year from now, when a new drug comes on the market. It's already subject to this separate copay tier.
Well,
I just had one other question to the
Yes, sir.
sort of options on the table. Obviously, Andy, you and the team have put together a lot of work to bring us these 7 potential options with 5 recommendations that you were proposing tonight. Were there any sort of options that were cut early that didn't make it to this that would potentially be up for reconsideration at this point?
So one of the ones I just mentioned was cut early, and it's one we looked at every year. And unless we would make a significant percent increase, would be to raise the employee premiums, more contribution.
Yep.
So, we only have, like I said, so many levers we can adjust. Benefits or revenue contributions.
Yep.
Cost containment strategies, we definitely look at those. Those are on the back end, the pre-authorization, those kinds of stuff, to make sure things are medically necessary. Those we count on our TPAs to manage those. We don't factor those into these types of recommendations. So that was a long answer to say, no, there wasn't a whole lot of other things we looked at. It's benefit plan design, rates, and funding.
Yep, that's helpful, thank you. And just to, again, get super clear, and we were looking at, I'm looking at attachment B. Of the options, it seems like option 1 and option 4, in terms of the proposals, are must-haves if we wanted to get out of the red and into the black. And the others help us start to build that fund balance to the desirable level. But there's no way for us to even be out of the red and into the black if we don't do both 1 and 4.
So 1 is already done. That was a budget process. We're
Yep.
going to start getting additional contribution already.
Thank you.
But yes, the other one that has a pretty significant impact was going to a single plan model. And just as an additional information, why would this be additional cost savings? Exactly what we've been discussing right now. It has lower benefits than the other 2 plans. So there's a coinsurance that goes to the employees that the plan doesn't have to pay. That plan right now is the one that's more appropriately funded for the benefits. So the amount of contributions between the district and the employee, it's keeping that fund in the black for the amount of claims that are being paid. Because the benefit ratio, to revenue ratio, all of those things are aligned about where they should be. The other 2, they are not.
Mm-hmm.
To right-size those rates would have to go through the roof manyfold.
Mm.
And that's something that we would never bring to you because they're not realistic.
Yeah. Thank you.
And I want to ask you one question on the question I had earlier about freezing the state plan or sunsetting it. Would that be fair to other employees who would not be able to then enroll in it?
So, judging by some of the sentiments, no. That if the sentiment is that we need plans, options, because employees have different needs, then we'll be somehow isolating some people potentially from not having access to those richer benefits.
Okay. Well, any further discussion? Any further comments?
You want us to look at it in some other ways to bring you something else? And let us know, we can do that too. I mean, I know that these are not easy decisions, but our health plan is to be balanced out also. But if we go back and, you know, bring you some recommendations, we still have to be in agreement that there will be some changes that we're gonna have to do anyways. But just let us look it over and see what we can bring back to you with the understanding that there will be changes that we need to make. Maybe not as like this, but some type of changes to the plans that we need to do.
By when do you need?
We could have it sometime towards the end of September. We still have time.
So I would say no later than the end of September, and the reason I say that is because we'd like to have 3 things ironed out for our open enrollment period. It's who our third-party administrators will be, so that we can make sure that they're aware during open enrollment that things are changing, new ID cards, those kinds of things. If rates are changing or not, you know, that's when we want to make sure our employees are aware. And then obviously, any benefit plan design changes that all happen, all that information needs to be in their hands on or about the enrollment period. I can probably move the enrollment late October, early November. That gives us a little more time, but we don't have a whole lot of time. Now, the other thing I would mention, this is a 1/1 effective date for these changes, if any changes are made, but decisions have to be made a little earlier than that so that we can make sure our employees are aware of what's changing or what's not changing.
I would say by the end of the September, no later than the end of September, to bring you some other ideas that we would have, but with the agreement that we need to make some changes. We gotta make some changes to save the plan and be able to
But
self-fund it.
My take on this is all a lot at once that was brought, and it's what's needed for the sustainability of the district in the future. With my fellow trustees that are there saying, well, it can be a shock to the employees. Maybe finding a tiered approach, as Trustee Haddad had brought in, would be something to look at. Realistically speaking, I'm seeing it, and I know it's something in the future that the district's going to have to do. If you look at, Dr. Gutierrez had mentioned TRS Active.
Yeah, active care.
So they're at a position to where I think employees that are on that plan, right, in the other districts are paying 70% compared to the 30%.
TRS Active Care, it's primarily, even though it's open to larger school districts, it's primarily the smaller school districts that jumped in. And I think they're finding themselves in they actually want to step out, and now they can.
Why would they do that, though? If you're a smaller district, of course, smaller revenues, smaller budgets, why would you go into a plan that's going to significantly increase costs for your?
Wasn't like that.
I
They cannot
can't
afford
speak
it.
for them. I can only
Can't be
speculate that they had visions that it was going to be managed and keep costs low and benefits reasonable, and it takes the administration away from them. So it was more of, all we have to fund is whatever is stipulated. But they see adjustments all the time, not only their benefits, but the rates as well, and they have no control. We're in the situation where we do have that control, but we have to make these, very tough decisions.
What we can do is, since we got United now and Araya, we can sit with them and talk to them about how they can help us maybe offset some of this cost and bring a minimal changes and with perhaps some savings that they can give us, since they're gonna start with, well, we already have Araya, but United, that maybe we can get some better savings or better pricing that they can work for us, with us, and then bring you some changes, but not as this kind of changes, but some type of changes that are more minimal
I
to
think
the employee.
at minimum, United Healthcare could come to the table and say, we're gonna help you with this.
Yeah.
And I'd really like if you could, have those discussions with them and kind of bring back a few more recommendations, or at least some kind of agreement on their part that they'll help. This is a big decision for our people, especially our staff that has had options. You're going to one plan, you're going to one basic plan, and that's hard for people who have been, like I have a high plan. I have an option of a basic plan and a high plan. I, of course, have to buy into the high plan because of everything that's going on. And at least I have that option, because it gives me better coverage and more opportunities to be able to take care of myself. So we're moving to one plan. I think we have a little bit of more help, or at least some recommendations from United Healthcare. It would help our employees to be able to plan, because they're gonna get one plan put in front of them when it's enrollment time, and that's hard when you've got other issues to deal with. That's at least what I would like to see. United Healthcare can come to the table with some help.
We'll work on that.
I
and-
mean,
and see what can.
it's the will of the board, but that would make me feel a little bit better.
That was the original plan anyway, to obviously have those kinds of discussions early on. We'll have to see what leeway I'm given to start those without having a contract in place, and, because we'd want to share data with them, so they can model things for us. I don't know how quickly they'd be prepared to start doing that, but
I think
we
they
need to-
want the contract.
we need to have that signed.
They should be able to talk to us about what they can do. That shouldn't be, I don't know how much I can talk to them about without a contract. They want the contract, they should be at the table.
I think this board is pretty open for us to have those discussions. You all good with that? So that,
Yes.
to be, because in the essence of time,
Yeah.
we don't have a lot of time. We only have this month.
Well, it's day 2 of this month, so, there you go.
Andy, are there supplemental health plans we can offer employees that have a lot, I guess, of usage?
So we offer supplemental health plans already for hospitalization and for accident. Those are on the voluntary side. Participation is not as big as some of those others. Like our disability, for example, I have a lot of enrollment in that. Cancer plans, standalone cancer plans, a lot of enrollment. Not so much in those Med-Gap type programs that help you offset some of the health plan related out-of-pocket expenses.
Okay, so we do actually offer some already.
We do, yes, sir. 2 different types.
Okay, well,
What would be the motion here to?
Tell me.
Motion to adjourn.
No action.
No action. I'd like to move that we take no action on, you proceed as, correct?
Let's discuss.
okay, I have a motion by trustee Peña to take no action and proceed as discussed. Do I have a second?
I'll second.
I have a second by trustee Haddad. All in favor?
Aye.
Aye.
All opposed? Okay, motion passes 7-0.
Thank you.
All right, thank you, guys. And now I need a motion to adjourn,
So move.
okay?
Second.
All right, I have a motion and a second. All in favor?
Aye.
All opposed? Motion passes 7-0. We're adjourned at 6:28 PM. Thank you, guys.